Good evening. Hello. We are here with I Care for Your Brain, another free science-based brain health lecture. I am Dr. Karen Sullivan. I am a board-certified neuropsychologist, very proudly. And we have been meeting here for about a year and a half, actually coming up on 2 years in October. And I was very motivated to do this to really be able to give you direct, good quality, science-based, evidence-based information about the brain. There's just too much bad information out there. Too many stories that have a little bit of scientific basis are being twisted for the profit of marketing companies who sell all sorts of junk that doesn't work to improve your brain. So I decided to do this as a way of using my blessings, my very positive, lucky experiences going to some wonderful programs and being able to be a neuropsychologist to perpetuate more high quality information out there about the brain. And you all have responded so kindly. We are coming up on 6,000 followers here on Facebook, which is just unbelievable. We've had a great response to our interactive stroke guide, which is for sale on our website, and we have all sorts of fun projects getting ready for the future. So I genuinely thank you all for being here. Tonight we're going to talk about something that is very near and dear to my heart, which is dementia, and we're going to specifically go into a subset of symptoms in dementia called behavior symptoms or behavior problems or challenging behaviors, psychiatric symptoms, neuropsychiatric symptoms. And these are important to me because before I was a professional psychologist, I was a caregiver. And I have had family members who have had dementia. And I know firsthand on those two experiences that it is these behavior symptoms that are the things that really break our hearts as observers of dementia. These are the things that unfortunately also frustrate us very much. And I'm going to share some data with you tonight that shows that these are the symptoms that drive people into nursing facilities. These are the symptoms that get people too highly medicated. These are the things that result ultimately in more mortality for our people with dementia. So it's really important that we understand them. And then I wanted to wrap up with some kind of mantras, some words of wisdom for caregivers or spouses that are out there that are living with folks who are having these symptoms. So one of the problems as we start to talk about this topic is that we still have a public perception of dementia as primarily a cognitive issue. So what do I mean by this? Is when you ask people to describe dementia, they talk about memory problems. They talk about forgetting their loved ones, not being able to remember how to get home from the store. But what we really know about dementia is that there's actually 3 sets of symptoms that always happen. Yes, one of them is cognitive, but the other one are these behavior changes or these mood changes. And then there's the impact on everyday life. And if you don't have those 3 symptoms together, it can't be dementia, it's something else. So when I say changes in everyday life, I mean the ability to drive to and from like you always did independently and safely, the ability to remember to take your medications, and the ability to remain independent financially. So we know that many people who have dementia also have mood and behavior symptoms, but they're not as systematically assessed or treated as the cognitive symptoms are. So one of the first questions we have is, why do we have these symptoms? Well, thank God we have done enough good quality research to know it's really the result of 2 different things. One of it is that it's just as much of a part as the degenerative brain conditions as a memory problem. So the same exact parts of the brain that are resulting in a person not being able to make new memories, say in the case of Alzheimer's, is the same part of the brain that you might also use to manage your emotions, to be able to suppress irritability. When your brain is working very well, your frontal lobes are healthy, you're able to have all sorts of inner experiences that other people don't ever have to see because you can push them down. When your frontal lobes specifically aren't working that good, it's really hard and you become very transparent. And many of us are walking around all day long with all sorts of harsh, difficult thoughts, but, we don't verbalize them. When we have dementia, it's not that easy to actually put the lid on stuff. The other thing is that the sad truth is that part of behavior symptoms are the way people with dementia are treated. People with dementia are ignored by and large. They very often will tell you that people don't speak directly to them as much anymore. They will direct their attention to another person in the conversation. Their friends don't call as much. They get left out of conversations. And we also know that there's not enough good quality information out there about dementia, even for direct caregivers. I mean, all the way from professionals, certified nursing assistants and nurses' aides, all the way to spouses. And so people don't necessarily know how to respond in the best way to dementia. And so sometimes we, even as well-meaning as we are, actually become part of the problem. So I want to talk to you tonight about the best ways to respond. How is it you can work on figuring out what is underlying some of these more difficult behaviors, because there's always reason. It's very infrequently just something that is out of thin air, right? The person's impaired brain is interpreting something in a certain way, having an emotional reaction as a human being, and having a behavior response. And it's the behavior response that looks so out of sorts and sometimes ugly to us, but really it actually makes a lot of sense in the big picture. So there's really 20 symptoms that we think of when we talk about these behavior symptoms. So the most common as it relates to dementia is agitation, apathy, which basically means a lack of interest, a lack of initiative, lack of motivation. Aspontaneity, which is again kind of just a little bit of flatness, kind of blah, not really motivated to get up and do much. Delusional symptoms, so that's like believing someone is coming into your house or someone stole your purse. Hallucinations, where you might actually see things that aren't really there. Depression. Disinhibition, which is that kind of not being able to hold back and maybe, acting in ways that are a little bit more childlike or primitive. Emotional lability, which is where your emotions are just all over the place, laughing one minute, crying the next. Euphoria, there are some people with dementia who are just kind of constantly on a high. Impulsivity, not being able to hold back, control one's impulses. Indifference, just nothing really seems to interest them or matter. Irritability. Lack of empathy, which is really hard for caregivers, so not being able to put themselves in the emotional position of the caregiver, not really being able to process what it means to be on the other side of this relationship equation. Loss of hygiene, loss of social skills, changes in the way people eat, doing something over and over and over again, and sleeping problems. So these are the most common ones, right? And like I said before, these are the ones that I think really break our hearts as caregivers. I think if dementia was just a short-term memory problem, was just a word-finding disorder, we would find ways to work with that. But in my experience, it is the person's lack of insight into what's going on with them and the fact that they actually need more help, they need new help, that causes a lot of heads to butt. If only the person with dementia could admit there's a change and that they need help, so many altercations could be avoided. But it is a neurological symptom that is called anosognosia, and it is something that changes in the brain where the person themselves really does not see that they are changing. They really don't see that they have a memory problem. But when you're on the other side of that equation, that's very, very hard. When personality starts to change, oh gosh, this is something that is just so difficult for us. When you go from dealing with a very sweet, normally docile husband, and all of a sudden now we have someone who is aggressive or irritable all the time, those are the changes that really, really hurt us, and we don't focus enough on them as medical providers. So people with dementia who have these behavior symptoms, they are much more likely to have a caregiver that's totally stressed out. That is usually the number one reason that people are institutionalized, is people are just at a loss for what to do. They're more likely to be what we call chemically restrained, which means that they get medications that are usually too strong. Delusions in particular are something that have been shown to really increase caregiver burden. So, that is when someone just really is fixated on a belief, some injustice that didn't really happen. And I think what's so hard about that for caregivers is we can't reason with them. We can't comfort them because we can't get them to believe that they're not waiting for their mom to come pick them up, even though they're 92 years old. We can't get inside their head to say this is your home, this is where you live now. Nothing we can really do in the kind of reasoning intellectual realm is going to work, because it's more of an emotional belief. So we have to be able to validate the emotions and then really kind of distract and move people on. That's what we need to talk about as a way of managing folks instead of just medicating them, right? So what I'm going to focus on for our lecture tonight is Alzheimer's disease specifically, and I thought you guys would be interested to know that they're starting to understand more and more that the very, very first symptom of Alzheimer's tends to be these behavior changes. And specifically, we think about 50% of people who go on to develop Alzheimer's start off having symptoms of apathy. So apathy just kind of looks like someone is maybe even depressed. Someone isn't interested in the things that they used to be interested in. Someone doesn't seem to have the same range of emotions. They're just kind of a little bit flat, right? And what we know is that this apathy symptom increases a lot as people move through the disease of Alzheimer's. So by the time we get to severe Alzheimer's, about 90% of people can be described as having apathy. This is, like I said, not only just kind of a flat emotional look on the face, it is that lack of interest, lack of motivation. Figuring this out is one of the reasons we are called upon as neuropsychologists, because it looks like, it walks like, it talks like depression. It is key to figure out, is it early dementia or is it depression? Because of course the treatments are very different, right? One of the things we do as professionals, you can also do this at home, is to ask content questions to the person to actually get at mood. So you can't rely as much on what a person looks like when you're trying to figure out this distinction between dementia and depression. You really need to ask the questions like, do you feel sad? Do you feel hopeless? Do you feel worthless? Do you feel guilty? These are the things that separate many times people with dementia and depression. Now guess what? You can actually have both. There's plenty of people who do maintain insight into the fact that they're starting to develop dementia, and it's very depressing for them. So for the most part, we're trying to figure out how much of it might be depression and how much might be dementia, and we are able to do that as neuropsychologists. So as we move into the severity of Alzheimer's, many people develop new symptoms in the behavior area of agitation and irritability. And this is, again, really, really tough for us as caregivers, because many times it is happening when we're offering help, when we're trying to help them do something that they were able to do independently before, and this just creates a lot of irritability and agitation. So it's very important that we do a very detailed analysis of why people are having these behavior symptoms, right? And so this is where your curiosity, if you ever wanted to be a PI or a detective, this is where it can really benefit you and your loved one. So I want to talk a little bit about something called the ABC behavior chain. And what this is what behavior analysts, what psychologists basically do to understand why a challenging behavior is happening. So what you can do is get a notebook and write a big old A, a big old B, and a C right there in the column, and then just start putting rows and dates. And anytime a behavior happens, the B is for behavior. So that's very easy. I want you to write in there what exactly happened that was so stressful. The A is called the antecedent, and this is actually what was happening in the environment that set the stage for it to occur. What was the precursor, the thing that was happening before? And the C stands for consequence, which is what exactly happened directly after the behavior. That can be how did you respond? That can be what actually happened to the person in the environment. After you make enough of these recordings, your job is to look for a pattern. Anytime someone does something once, that's not enough data to figure out some of the underlying causes. So what you're going to try to do is record all the times there's agitation. And then once you have about, maybe 5 to 10 examples, you're going to try to take a step back and say, okay, what were the common threads? Was it happening often when the television was on? I can remember with my grandmother who had Alzheimer's that she started to think that the people in the television were actually in the living room, and that would irritate her because they weren't talking to her, and she would start to get miffed that she was being ignored. You can try to figure out the environmental context. Are they pretty calm at home, but when you go to church, this is where some wandering happens, some agitation happens. You can think about what happens after. Do they go into the bathroom and they're maybe having some difficulty there? Are they calmed down after you offer them a glass of water? So you want to try to get very mechanical about the before, the during, and the after. So one of the biggest keys, though, is how do we respond? People and the environment are one of the biggest triggers. And so we have to ask ourselves and get real with ourselves. Was I calm? Was I agitated right back? Was I overwhelmed? The more trouble we have with language when we become demented, the more the nonverbal behaviors matter. And what I mean by that is our tone of voice, the way we turn our body, the even, direct, clear things like clenching our fists, feeling like we can pull out our hair. So you want to look at several incidents over time and basically try to figure out, okay, am I responding in a way that might be based on being overwhelmed? And that's where it's so important to be able to write these things down to get a little bit of a mental buffer, because we all know caregiving is hard. When you're in the moment, it's very easy, just like it is with any kind of caregiving, whether it's a puppy or a child or someone with dementia. It can be draining, and the more tired you are, the less amount of patience that you have. So when we look at the research data and we analyze the environmental triggers, there's really three that seem to come out. The first one is being overwhelmed by stimulating surroundings. So this is too noisy, too bright, too loud, too many choices. You want to try to really simplify things in the environment of the person with dementia. The next one is kind of related to being overwhelmed, actually, but it's an unfamiliar environment. So a lot of times this can bring up some of the more aggressive behaviors or restlessness and the need to wander around. This is anywhere from being in a grocery store to being admitted to the hospital. The bigger the change, the more significant the behavior symptoms can be. And the third one is actually being ignored. When I was an undergraduate at Clark University in Worcester, Mass., my honors thesis was getting a bunch of people who had just been diagnosed with Alzheimer's in a room and doing a focus group with them. And my question was, what do you want people to know about having Alzheimer's disease? And the response that almost all of them gave was, stop ignoring me. Don't talk over me. Give me a little bit more time to respond. Don't act as if I'm not there. Don't leave me behind in conversations. And so if our feelings are getting hurt and our very basic human need to remain social and included and seen and validated is not happening, then we are going to find a way to express ourselves, especially if our brain is not healthy and we're not able to mumble under our breath or, maybe pick at our nails under the table. It's like I said before, our lid doesn't work as much. We're much more transparent. So it's going to potentially come out in aggression or irritability. Medically, the most common trigger for behavior symptoms is hands down urinary tract infections. If you ever feel like all of a sudden your person is acting much more impaired or they're much more confused, please, please, please go to the primary care office and give a urine sample and see if they will test them for UTI. So when I talked before about our reaction, right, I focused a little bit on overreacting, right? So if we kind of jump on the person and, you need help and, I'm here to do it for you, and we get a little bit forceful, that's not good. But it's also not as good if we actually underreact. And so we don't want to also pretend something's not happening. We used to advise that with dementia. We used to say totally ignoring the behavior and distracting was the best. But thank God we've become more progressive in our approach, and what we now know that we want to do is really try to understand the emotion underneath the behavior problem and to validate that. So for example, building on something I said before, if someone is living in a facility and they are perseverating, going on and on about wanting to go home, many of us interpret that as not necessarily wanting to go home to a previous physical surrounding, but feeling lost within themselves. Having memory, making new memories, is very, very grounding for us as people. This is how we feel like we know who we are and how we feel safe and what's going on in our environment. And so when we don't know that and we are confused, even though we might not be aware we're confused because we have Alzheimer's, there is, I believe, a part of our psyche that registers that something isn't right here and I want to seek safety. And many of us think of our home as our safest place. So instead of taking it literal that they are waiting for someone to come pick them up and trying to reason or rationalize with them that this is where you live now, it would be much more healthy, much more helpful to actually just talk about, I wonder if you're feeling scared. I wonder if it feels like you wish you had somewhere you could go that would make sense to you, that you would feel more secure at. And what you find a lot of times is people, especially if you look to the nonverbals, people do give you reassurance that underneath that is actually exactly what it is they're wanting. So what then you're going to try to do, yes, is distract, try to change environments, try to get them up if they're down, try to, oh, I need you to, help me over here with a glass of water. Try to mix it up, but you also want to try to meet that need that you were able to figure out. And so what you can do is try to create a very secure, comforting environment. You can find maybe another room that's a little less overwhelming in the facility and maybe have them go into a chair with a nice blanket and you can sit down and just try to one-on-one do things that feel more connecting to the person. You can talk about, what was your favorite chair you ever had, or, you can talk about long-term memories. Those are very often still very secure. So you want to look for that underlying emotion, validate it, and then basically move on. It's really not productive to stay in that conversation for too long, but you really want to address the underlying emotional need and then kind of transition to something that will help the person's mind get off of it. But we also don't want to be Pollyannas here. We don't want to be naive, and there's plenty of times where the very best intentions don't work, and sometimes we really do need medication to treat a person humanely with dementia. We don't want to over-medicate, but there really is, in my opinion, a time and a place for meds. So when that happens, we do rely on things like low-dose antipsychotics, antidepressants, benzodiazepines, things like that. These don't really work that great. We think they're kind of modestly helpful. There's definitely risks that go along with them, and in many cases, so we're basically replacing one problem with another. So what we recommend is non-pharmacological interventions. This should be our first line of treatment. Before we go to a pill, we should respond interpersonally and humanely to the individual. So I want to make sure you all know about a fantastic educator named Teepa Snow. Do any of you know about Teepa? I had the very good fortune to be at a training with Teepa recently here in North Carolina, and she approaches these problems, challenging behaviors, she calls them, from a positive approach to care. And so she's got all sorts of free resources online. When I'm done talking, I'm going to put her website in the comments. And she is a great person to learn more in-depth information from about this topic. But what we try to focus on is things like reducing the stimulation in the environment, reducing boredom, helping people be more physically active, giving them experiences that make them feel like they can predict what's about to happen. The best thing that I've found for that is music therapy. People remember melodies and song lyrics well into very advanced dementia, and the psychological experience of being able to anticipate words or being able to predict the beat and be a part of that beat with your body, those are things that, if you've ever seen someone with dementia have that experience, are so clearly soothing and organizing and comforting to that person that one of the things I'm going to be focusing on in the next year in my community is trying to get more music therapy into facilities, because it is just so powerful. So this is where, activity programs come in. One of the big things that prompts these behavior symptoms is boredom. If you have ever gone to a memory care facility, it is striking how little there is going on. If you get a TV on, you're lucky. There's and believe me, I used to be an activities director in a memory care unit and assisted living. And so I know the challenges of doing that, and I'm not being critical. I just think that just the priorities and budgets are just not there to really support full humane activities in these types of environments. So for a lot of us, it comes down to finding volunteers in the community and getting people out of the goodness of their heart to come in and be able to offer something. So that's a very important way you can contribute if this is a meaningful topic to you. So I wanted to end tonight by just talking a little bit about kind of some mantras for caregivers who are maybe going through some behavior symptoms. So I want to start off by saying that everyone who has dementia is different. No two brains are alike. Every caregiver is different, and so I don't want you to think when I read this list here that this should always be applicable to you. It's just some kind of food for thought to maybe validate you. So many people who are caregivers, in my experience, have set the bar so almost impossibly high for how patient they should be or how understanding they should be, and it's just not realistic. And so I think it can be very helpful to hear from a professional that really doing your best more often than not is all that's required. So I'm going to do the first 5 tonight, and then we're going to talk more about this next Wednesday. So the first one is being logic-driven and reasonable and rational is not going to work the more someone goes into dementia, okay? And if this is the way you were always in relationship with this person, that's gonna be a hard thing to change. And so a lot of us try to negotiate in life. We try to say, but don't you remember the last time when you did this? Those things are not necessarily going to work anymore. For someone in the past, we might have thought it was very respectful to include them in decision making and to help them make the best decisions possible for them. But the truth is as dementia advances, less is actually more. We want to make sure that we are limiting options because that actually leads to more quality of life because that feeling of being overwhelmed is not there, right? With too many choices, the person with dementia is being asked to hold multiple things in their memory at one time and do a comparison. That cognitive ability is exactly what's lost as the person becomes more and more impaired. So we don't need to be using the same interpersonal approach with the person with dementia that we maybe used before. Now it's a fine line because we want to be as respectful as possible, but the relationship and how we communicate and how we negotiate, it does change because of the dementia. So we have to learn how to change with it. Number 2 is that people with dementia do not need to be grounded in reality. And actually, let me back up one second because I'm not making these up. These are actually guidelines from the Family Caregiver Alliance, which is at www.caregiver.org. I wanted to say that so I'm not plagiarizing. But this is a big thing that I get questioned on is if they don't know the year, should I tell them the year? If they think tomorrow's Christmas, should I tell them it's Christmas? It's really not our job to make sure that people with dementia are redirected back into reality, right? What we want to do is when there is confusion or disorientation, what matters most is if it bothers the person. If it doesn't bother them and it's just a repetitive question, there's really no need to redirect. It's up to us to become more patient and figure out how to respond to the same possibly frustrating question over and over again. If it is a question, a perseveration, a delusion, a disorientation that seems to bother them, that's when you want to do the analyze, validate, and reflect. But if it's something that really doesn't matter, it really isn't our job to hold that person's feet in reality. Number 3 is that there is no perfect caregiver, just as there's no perfect parent, as they say on this website, that just because you're a caregiver doesn't mean you suddenly sprouted wings and became an angel. You are allowed to be frustrated. You are allowed to get mad. You have to figure out in this caregiver journey how it is you are going to be kind to yourself, just like you're trying to be kind to the person that you love so much. Number 4 is that white lies reduce stress. This is something that can be very difficult for people to appreciate, which is, I never told my wife a lie in our 45 years of marriage. Well, if you're someone who values honesty, this can be very, very hard and it can cause stress. However, you can get a lot more easygoing flow to your day, a lot more compliance, a lot more going along with medical advice by learning how to be comfortable with little white lies. So there are plenty of times people come into my office and I know that they weren't told before they got here today that they were coming to see a memory doctor, because if they were, they might not have agreed to come to the appointment. But we're going to go out, let's go get a milkshake, and oh, by the way, I just heard about this nice doctor, we're going to stop in and say hi. We have to always make sure that for people with short-term memory problems, we're not actually causing them more harm by introducing ideas too early, right? Especially things we know are going to stress them out. They're not going to remember anyway, but they might be left with the emotion of stress, of worry, of anxiety, and then not be able to cognitively tie it back to the thing that triggered them or stressed them out. So it's very important to learn about pacing and to not feel badly if sometimes you have to fudge the truth a little bit. And the last one is making agreements don't work. This kind of goes along with the person doesn't have to be based in reality. If you ask them to do something and they don't, it's really not fair to hold that against them in the future, right? In the beginning stages of dementia, we can leave notes, we can have a whiteboard. We sometimes can provide cues and reminders, but as the dementia progresses, this is not necessarily going to be something that helps, and having an expectation that it might only lead to frustrating you more and potentially shaming that person a little bit. Not that this is ever anyone's intention, but if you don't have education about dementia, you're just coming at this person as if you always did in the relationship. And it's just key that you find places, especially here online, that are free and comprehensive and science-based, that will help guide you in figuring out a new way to approach this person. It will really help your quality of life, and I think also reduce the chances of these folks having these behavior symptoms. Many of us interpret behavior symptoms as just another form of communication. Communicating what's going on with us emotionally is a very basic human need, and it's really a right. And if we aren't allowed through our brain disease or in our environment to get those things out, believe me, they kind of eke out all sorts of different ways. So we want to try to understand the language of the person with dementia and also change the language we use with that person. So next week, I'm actually going to go through the next 5 with you. If you have any questions specifically about these behavior symptoms in dementia, you can write them here and I'll include that in my talk next week. I would love to know about your experiences. What has worked for you? What didn't work for you? I know that sometimes it takes all sorts of creative problem solving. I was remembering recently that with my grandma who had Alzheimer's, nighttime, sundowning was particularly hard for her, and she was someone who always enjoyed a drink. And so this was in the 1990s, and we didn't really know who to go to for help. And so every night she would have a cream de mint, which was a little nightcap for her, which was really mint NyQuil. And it was something that just kind of helped make her sleepy and a little bit less of a handful. It's not something that we're very proud of now, knowing that there were probably other ways, but I also believe in any port in a storm and not judging people when they have to do things out of desperation to provide comfort to someone who is struggling. So thank you guys again for being here with me tonight. I really appreciate the chance to spread some good knowledge and help you guys out there. So please join me again next Wednesday at 6 o'clock for part 2 of this conversation. Have a great night, everyone out there. Bye-bye.